So our task this morning is to go over the gastrointestinal system, or what technically we call the abdomen from the point of view of examination. And so let's start with symptoms and then go on to physical examination. To begin with symptoms, you will remember in the cardiac and respiratory system, we emphasized important symptoms to remember. And if we look at the equivalents are the same in the gastrointestinal system, the way I do it myself is I remember symptoms in two main blocks. One, the symptoms that I forget, and they're always the same. It's weight loss, it's loss of appetite, and what I call asthenia. In other words, somebody not just having the strength or the power. It's non-specific. So, but of those two, of course, it's the loss of appetite and the weight loss are most important. So having got rid of those, as it were, and asked about them, the best way I remember the gastrointestinal tract is to start at the top and work down to the bottom. And very simply, you start up here and say, do you have any difficulty swallowing? Now, we don't ask, do you have any difficulty initiating swallowing, which is deglutition. But in practice, the generic question picks it up. Do you have any difficulty swallowing? And then where? At which point? High up, middle, or low down. That's it. And of course, there are 2 or 3 non-specific symptoms that kick in at this stage that students need to be reminded of. One is heartburn, or this acid feeling that you get retrosternally, sometimes after a meal. The other one is water brash, where your mouth actually fills up with some saliva, or a taste what we call a tasteless fluid. Those 2 are very non-specific, but they may be associated with peptic ulceration. So students sometimes have to be reminded that you often have to ask, do you have any difficulty in swallowing, of course, and then pain. Now, pain in the abdomen is a huge thing, because pain can occur anywhere from the mouth to the anus. But then immediately, 99% of pain is in the abdomen per se. And there are 2 types of pain in the abdomen. One is related to viscous, a hollow viscous, and the other is related to the peritoneum. One is colicky, the other is continuous. Now you're taught to ask the 9 points about pain: the site, character, how severe it is, the nature of the pain, and what we call aggravating, relieving factors, associated factors, any past history. So I am reminded that you have to go over those in the gastrointestinal system. Probably before I've gone on to pain, I should have mentioned things coming back up. And the big one, of course, is vomiting, and the other one is flatulence, or gas or air coming back up. Now, vomiting, of course, is big, and vomiting is a major complaint in the gastrointestinal system. And just like the respiratory system with cough, you have to ask what is in it. If there's blood in it, then it's hematemesis. And that's it. And of course, with all these symptoms, you have what's called a time course, an onset, a duration, a frequency. And you've got to kind of work through them, as it were, with checking for those particular aspects. Now, I've mentioned to you anorexia and weight loss, or loss of appetite, losing your weight. I mentioned difficulty in swallowing. I just did a little aside on heartburn, water brash, or reflux. And then we mentioned vomiting, hematemesis, and we've mentioned pain. If you notice, we're working our way down through the abdomen. And the next big group of symptoms is all about bowel habit. And bowel habit is what it says is your bowels opening, and the frequency and the content. Now, diarrhea by definition is defined as greater than 3 bowel motions per day, or an increase in the, what we call the looseness or the content of the stool. That is different. So you do ask about bowel habits, the frequency of them passing the stool, and then what is in it. What is in it divides itself up rather easily into big categories. Normal stool, form stool. Is there something else in it? And specifically then is going to be blood, and this is the one the students don't forget is melena, what we call the black tarry stool that's associated with bleeding above the ligament of Treitz or in upper gastrointestinal tract bleeding. Of course, there are other stools. For example, in obstructive jaundice, the stool is pale, and of course, it's in diseases like malabsorption, it's foul-smelling and associated with flatus, gas. And so, reminding you again then that in terms of the abdomen, there are not that many symptoms that you have to go over. The devil is in the detail. It's in the abdomen that you really have to take each symptom and go through what's called, we call it the history of the presenting complaint. So, I don't really have much more to say about the gastrointestinal tract. We are emphasizing main symptoms, big ones, the ones that you do not forget. The past history, family history, social history, drug history, allergies, systems review, and in females, gynecological and obstetrical history applies, of course, to gastrointestinal as well. In terms of past history, it's obvious if you have a history of what we call abdominal disease, like take a disease like liver cirrhosis, take a disease like ulcerative colitis, Crohn's disease, or just what we call a disease like diverticulitis or whatever. So if there is a past history then of a gastrointestinal disease, it's got to be documented. If there's any hospitalization with it, and in particular any surgery, any operations. So I'm emphasizing that for you. Family history, some diseases run in families. Gastrointestinal one, celiac disease does. Familial polyposis and cancer of the colon does. And some diseases are associated in family because of exposure, like tuberculosis of the gastrointestinal tract. So family history is important, particularly with first-degree relatives. And social history, I think the gastrointestinal tract emphasizes alcohol, the type, the quantity, the duration. Smoking is indirectly associated with malignancies of the gastrointestinal tract, increased risk. And of course, occupation. Is there any disease any particular disease you're exposed to at work by virtue of your occupation? Meat eating in the West is a high-risk disease, is a risk factor for carcinoma of the pancreas and possibly colon as well. So we're finished then with we call the main histories, and I think I've emphasized what I needed to say about the symptoms in the gastrointestinal tract. Just before I move on to that, there is no area in the body, if you notice, where we look at the genitourinary tract. We tend to kind of lump it in with the abdomen because it's all in the abdomen. And all I'm saying, it's a good time to remember the main symptoms of the genitourinary tract that you ask about. And you ask about their urinary frequency, day and night. Do they have any difficulty or pain on passing urine? And then you ask about the urine content. Is it normal or is it abnormal? And if it's abnormal, what do they mean? For example, we live in an area endemic for schistosomiasis, particularly hematobium, when passing blood in the urine is almost considered to be normal in hyperendemic areas. I'm just emphasizing that it's a good time to remind you not to forget the genitourinary system, because when it comes to the examination, we're going to examine the kidneys and the genitalia at the same time as the abdomen. And that completes then my symptom review of the gastrointestinal tract for today. Thank you. So let's start then with the examination part of the gastrointestinal tract, which is usually termed examination of the abdomen. And I always remind students that there are two parts of the examination. One are the peripheral parts, and two, the examination of the abdomen proper. Remember, you had exactly the same with the respiratory system. You had the peripheral parts that students tend to forget, and then the main part, which is the bit they concentrate on. So, to start with, we'll start with the peripheral parts of the examination of the abdomen. If you note, I've put the patient sitting at 45 degrees for this part of the examination. For the examination of the abdomen proper, the patient will be lying flat, ideally with a little pillow under his head, so his abdomen is relaxed, with his arms by his side, and the examiner will be sitting comfortably on a stool beside the patient. So going back to the peripheral parts, they're relatively simple to remember because it's a reenactment of the other systems. You start with the hands, and then you move up to the head, and you examine the neck, and you also examine the legs. Now, what do we look for in each part? Well, the hands in the abdomen are huge. Clubbing, anemia, chylonychia, what we call liver palms, Dupuytren's contracture, liver flap. The list goes on and on and on. So you must look at the hands in the gastrointestinal tract. The next part of the examination, of course, comes up to the head and neck, and in particular you're looking at the conjunctiva here for jaundice, evidence of jaundice, or anemia, or anything else that strikes you. The mouth is the portal of entry to the gastrointestinal tract, and of course this is where we see the features of anemia on the tongue, particularly flattening, loss of papillae. You also see all the abnormal syndromes, telangiectasia you see here, like Peutz-Jeghers syndrome, that's rare. Kaposi sarcoma is common, metastasizing to the gastrointestinal tract, so we see it frequently in the palate. So I emphasize that the oral cavity is the beginning of the gastrointestinal tract, and if you remember, the next equivalent part is going to be the rectum. The rest is out of sight. Coming down to the legs, what do we see in the legs with regard to the gastrointestinal tract? You'll see edema in cirrhosis with low protein. You will see pretibial ulcers associated with ulcerative disease like ulcerative colitis, Crohn's disease. You may see bruising in chronic liver disease with clotting problems, and so on. So I'm emphasizing, please don't forget the peripheral bits. There are some lymph nodes that need to be examined with the gastrointestinal tract. Starting in the supraclavicular fossa, you have what we call the node behind the clavicular head of sternomastoid. There's a scaly node tucked away down behind here, and that is the satellite node for malignancy, usually in the stomach. It may also signal malignancy from the pancreas. So don't forget to do that. I'll demonstrate how to do it. Students tend to forget that the inguinal area and the femoral area is part of it drains the lower end of the abdomen and the genitalia. So if you don't examine it in this system, you don't examine it in any system. Equally so, genitalia are the lower extremities of the gastrointestinal tract, and this is the part we include them in the examination. I'll refer to that in a bit more detail when I come to the examination of the abdomen proper. So moving on to the abdomen proper, if you sit up for a minute, Freddie. Now, in Freddie's case, looking at his hands, he's a student, so we don't expect any abnormality. I've mentioned the things you look for. You obviously look at his conjunctiva, and if you want to look for jaundice, Freddie, okay, can you look down, please? And you expose the conjunctiva. Looking for jaundice in the mouth, we ask the patient to please bring your tongue up to the roof of your mouth and look at the frenulum. That's the best place to see jaundice. I've emphasized the other parts. Obviously you expose the legs, and of course you have lymph nodes. And I mentioned that this is the area where we check for lymph nodes, and particularly behind, this is going to be the medial or the sternal head of sternomastoid. This is clavicular head, and tucked away down here we have a node that may be easily missed. And we'll come on to the inguinal nodes a little later. So with that in mind then, Freddie, if you don't mind sitting up, we're going to lie flat, please. And you need to expose the abdomen as far as what we call the pubis. So could you just undo your belt there for a minute? I'm just going to take it down to his anterior superior iliac crest for this part of the examination, so as not to embarrass him. That's perfect. But you see, the importance there is that this is the area of the abdomen. Now he's now ready for examination. And the important bit is the patient is ready. Now is the examiner or the doctor ready? Well, ideally, you need to be in a comfortable place at the side of the patient. You are going to walk to the end of the bed to inspect from we call it the front or the anterior view. And what are we looking for then on inspection? Well, you can see here the thing that strikes you most is the abdominal breathing. In other words, the type of respiration. Moving his abdomen symmetrically, there's no obvious swelling, no distension, no pulsation, no abnormalities in the skin. What do we look for in the skin? Well, varices, distended veins. You might look at the umbilicus. Is it inverted or everted? Everted as in caput medusa, with portal hypertension, or reversal of venous flow. So I teach the students, this part of the examination is important, particularly when there's an abnormality. And we also teach the students to go to the end of the bed and inspect from the end of the bed. What am I looking for here? I'm looking for asymmetrical swelling of the abdomen, and also this is where we see flank distension. You may miss it from the side of the bed in ascites, whereas a pregnancy is a midline structure, ascites is a generalized structure. One will have flank distension, the other won't. Inspection then is a very important part of the abdomen, as I say, when there is an abnormality, and that is self-explanatory. The next part of the examination is probably the essence of the abdominal examination, palpation. And what we teach here, and this is where we divide the abdomen up into what we call anatomical parts, so that when we come to describe the abnormality, we can name it. Now, most students know this. There's an easy one in quadrants. And all you do is a line through the umbilicus, and horizontally and vertically. And that will give you right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. That is fine, but of course it's not detailed enough. That's why we have 9 divisions. And to get 9 divisions, you have imaginary lines again. One, the vertical ones, very simply, are through the mid-clavicular line, or the mid-inguinal point, a line joining them, right and left. And the horizontal ones are the subcostal margin here, the subcostal just under the rib cage, feel for the ribs, a horizontal line there, and then a line, go on to the superior iliac crest and feel for the anterior spine, and a line joining that below. And that divides us up into 9 areas. The upper ones, this is hypochondrium, a right and left hypochondrium, and epigastrium in the middle. And then you've got a lumbar area and a right and left lumbar area. And then you've got a right and left iliac fossa and a hypogastrium below it. So these are the 9 divisional areas of the abdomen that the students have to remember. The importance is when it comes to anatomical description. Palpation then, to go back to that, we start now in the right iliac fossa with superficial palpation and move in an anti-clockwise direction to complete a circle and then go across the midline. I'll demonstrate how to do it. It's done with light palpation. In other words, the patient is comfortable, he's warm, your hand is meant to be warm, it's always warm out here in the tropics, so that's not essential. And you start here. Now the important thing is, you saw him wincing when I put my hand on his abdomen, is look at the patient's face. And you can ask the patient, do you have any tenderness in your abdomen or any soreness? No. If it were, I would start at the most distant point away from it and then work towards it. And that's a principle in abdomens. Don't forget that the task here is to pick up any abnormality. And broadly, they're in two groups. One, where there's inflammation underneath, where there's going to be some what's called guarding or muscle rigidity. Then there may even be rigidity at rest, the muscles are in spasm, or there may be rebound. If you take your hand away, it causes peritoneal pain. And this all indicates inflammation underneath. There may be masses, there may be organomegaly, or there may be some other abnormality. So your task then is to try to, by palpation, is to feel if that abdomen is normally abdomens are soft. And the main organs may not be palpable, and we'll demonstrate those individually. Starting then in the right iliac fossa with the flat of your hand, just gently looking at the patient's face, and you dip your fingers by moving them here at the metacarpal phalange, just very gently dipping. See that? That's all I'm doing. It's very gentle. I'm looking to see is there any abnormality. Very gently. I'm going to the area of the spleen, because if the spleen is enlarged, I should feel it now, because it's a superficial organ. The liver is different. I won't pick up a liver this way unless it's very enlarged. Keeping an eye on the patient, complete the circle, and then make sure you go across the midline at least once, because you've missed it with the circular method. Now, what is different between the next method, which is deep palpation? Well, deep palpation, you use all of your hand. It's the whole flat of your hand you're now pressing. You're still dipping, but you're feeling, you're going deep. Some people use two hands, like that. It gives them more leverage. Personally, I just use one hand, and if I get an abnormality, I may switch to two. Again, looking at the patient's face, and I'm moving in an anti-clockwise direction. I'm not feeling anything. I move over his splenic area, nothing. Nothing over his renal area there, and up his liver. I'm not feeling anything. And now again, I complete the circle, what we call anti-clockwise, and then I go across the midline, and it's a deeper form of palpation. But that is insufficient on its own. Now I have to check out each organ. And were a spleen to be enlarged, it would lie in the concavities of rib 9 to 11. It would be superficial, and there would be a leading edge. It would move on inspiration, and I could percuss it. They're the 5 characteristics of a spleen. So let's check if Freddie has a spleen. The way we do that is we start in the same position, the right iliac fossa, and move now diagonally towards where we suspect the splenic enlargement, looking at his face. It is superficial, and let's imagine I feel an edge here. What do I do next? Well, keeping an eye on his face, now I just feel the edge. There'll be an inferior border, there'll be a leading edge, and a superior border. And on the superior border, there should be a little notch, a V-shaped area. And that will, once I feel that, I know this is a spleen. I already suspect it is. The next thing I can do is ask him to take a deep breath. Freddie, just breathe in deeply. And if there was a spleen there, that edge should come and hit my fingers. It should nudge them, or you feel it. You keep your hand still while the patient is breathing. Freddie, take a deep breath. And it's the leading edge, the leading tips of your fingers I'm using. Finally, I could percuss it. And again, I'm parallel to the enlargement, if you listen. Now listen for an area of dullness. Do you hear it? Of course, I'm cheating, because I've lifted my finger off the abdomen just to give you a dull note. And in theory, if there was an area of dullness there, it would indicate that there is likely to be a spleen. Now, but it could also be a kidney, couldn't it? So the only way we can differentiate the two is to be able to examine for a kidney. Now, I'll demonstrate examining on the right side first, and then go over to the left side, the way we do it in practice. Kidneys are difficult to feel. They're paravertebral. The right one is lower than the left, and please remind me if my anatomy is correct. As I remember, the left one lies parallel to the bodies of the 12th thoracic vertebra and the first 2 lumbar. The right one is a little lower because of the liver, and is parallel to the first 3 lumbar vertebrae. That's its anatomy, and it's paravertebral. It's deep and retroperitoneal. It's a retroperitoneal structure, so difficult to feel. Most times you're just feeling a lower pole of the kidney, and that's why. And It also moves on inspiration, just like kidney, it's just like a spleen and a liver. So let's imagine I'm palpating for a kidney here. Freddie, you can relax there. I'm just going to put my hand here. I put my hand behind, under the, what we call 12th rib, and above the iliac crest, in the loin area, just gently. And I put one hand in front, in the area now where I suspect that the kidney might be. Please note my fingers are very near the midline. And then I do what is called ballottement. Ballottement is when I flick from behind or push from behind with my posterior hand, and I feel the ballottement with my what we call anterior hand, or the hand that lies over the abdomen, okay? And in that way, I check if there's any obvious mass there. Lastly, I ask the patient to take a deep breath. Freddie, can you take a big deep breath in, out, and I just go down a little bit, in, out. I think I can feel maybe, but I couldn't be certain. He's got strong abdominal muscles. Now, in practice, the way we do the other side is we often get lazy and switch like that. Use the same hand for ballottement and the same for palpation. That is a recognized method in practice, all right? And again, Freddie, take a deep breath. Yeah, I may feel a little kidney there. In practice, I should actually go to the other side and repeat the same maneuver as I did on the left. Switching hands. And again, check for ballotment. And you won't be able to ballot a kidney that, unless it's slightly enlarged, as a rule. It's a test for kidney enlargement, ballotment. Now, what about the liver? Well, the liver causes students a degree of difficulty, and with good reason. The first thing, it's a deep organ, it's not superficial. It may become superficial when it's grossly enlarged, and we see that many times on the ward. The normal liver is usually a subcostal organ, and that comes down on inspiration. If you note, all three organs move on inspiration: spleen, kidney, and liver, because the diaphragm pushes them down. The diaphragm has and it is what we call upwards and downwards movements, pushes the abdominal organs down. So to examine for a liver then, we start in the right iliac fossa with deep palpation using the tips of your fingers. You stay lateral to the rectal sheath, like this. You're pressing deep, deep, and upwards. Now, breathe in. Breathe out. I don't feel anything. Lifting my hand, and then I move up about 2 centimeters. Breathe in and breathe out. Pressing in, slightly upwards, all the time checking for an edge that's going to come down and hit my fingers. My palpating hand is still while he is breathing. Please note that it is deep palpation, and you may sometimes have to use your other hand to support your what we call your palpating hand. Finally, come up here in the area where the liver might be. Take a deep breath, and now I can feel an edge. Just coming down from under the rib cage, hitting my finger. Now, to confirm that, I can actually do percussion. And this is the time to do it. Let's percuss out his liver and measure his liver span. If somebody has a measuring tape, then I would appreciate it. Let's start with percussion up here and listen for the sound. If you listen for the sound, you'll hear it. Okay. Resonant. This is busy outside, but resonant. Resonant. Dow. 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 Resonant. So Freddie's liver span is actually quite by our method. We're getting something there, and then I just backtrack and confirm. There. It gets the liver span about there. Sometimes we say, if you notice what I did there, I did loud percussion up here and soft percussion down here. That's the way we do it. The method is slightly different for over ribs versus over abdomen. Soft percussion over the abdomen. hard percussion over ribs. Now we can measure this span, and the normal liver span is between 8 and 12 centimeters. Now the percussion method underestimates the size of livers by a couple of centimeters. You know, we've demonstrated to you the methods of palpation, we've demonstrated the main organs, the main three, and the other hypothetical situation is a mass. Now, a mass could arise, a uterus is a mass, an ovary is a mass if it's palpable, a tumor is a mass, a cyst is a mass. So, when it comes to a mass, there are about 10 characteristics that you must define. In principle, you all know them. The site we just mentioned, remember? The size is going to be important, the dimensions, the width, the length. The immediate characteristics, is it regular, irregular, pulsatile, non-pulsatile, tender, non-tender? Is it mobile, non-mobile? And then any other characteristic that strikes you. Please note that when you just say there's a mass in an abdomen, you have to describe its characteristics. Because when we describe its characteristics, it determines what it is likely to be. For an example, a bladder will gradually push up into the hypogastrium, and it will be rounded, smooth, midline, and you'll be able to percuss it. Pregnancy is the same way. A 12-week-old pregnancy begins to appear out of the true pelvis into the abdomen. And of course, our big disease here is ascites, secondary to portal hypertension. Now, all students know how to demonstrate ascites, but when it comes to the technique, there may be problems. And I'll review the technique with you now. Please note that I'm moving on to percussion. Moving on to percussion. Before I do that, I should say some principles. We percuss from resonant to dull. That's the principle. You percuss from resonant to dull. And using that principle then, if we come on to demonstrate ascites is fluid in the abdomen, it will be in the flanks in the dependent patient, therefore you start at the midline. You don't start over the dullness, you start at the midline, and listen, you should only tap twice. If you're tapping more than twice, you are not concentrating. Okay? Or it's too noisy. Now, let's imagine he has an area of dullness here. What do we do next? Well, what we could do is mark the abdomen there. I could do that. Okay? That's the area of dullness. Now I'm going to demonstrate if it shifts. So I'll ask the patient, please lie on your left side. Now I will hold my finger in that position for about 10 seconds because that's the way I do it. I expect the dullness to have shifted because the fluid will have moved, and now I percuss, okay? And now that note theoretically has changed from dull to resonant. Of course he has no ascites, and I'm palpating his, what we call his lumbar muscles here, or his flank muscles, and they're a little bit dull. The other way, as I said, take your finger away, and now I've marked it. You wait 10 seconds and just percuss over that. That's the way we demonstrate shifting dullness. The other method is fluid thrill. And fluid thrill is the principle that you create a little waveform in water or in fluid if you move it. The tsunami effect, we call it. And the way we demonstrate that is we ask the patient to put their hand in the midline. Press firmly, you put your palpating hand over the flank, and with your right hand, if you're right-handed, or left hand if you're left-handed, you flick the what we call the corresponding flank on the other side with finger, like that. And you create a waveform, and you should be able to palpate it on the palpating hand as a thrill, and that is called a fluid thrill. It's very obvious when the abdomen is fairly tense. Tense but not full. If it's full, you can't demonstrate a waveform. There's no space for it. So that's one of the caveats with fluid thrill. But of course, with dullness, it will be fully dull. So, as it were, the last part of the examination of the abdomen is to do with auscultation. And this often causes confusion to students. One is, which part of the stethoscope should I use? Well, theoretically, they're often high-pitched sounds, and you may hear them best with the flat part of the diaphragm. If they're low-pitched, you have to use what's called bell of the stethoscope. I don't have one, but you know what I mean. where do we place it? Well, you're interested in movement in the bowels, both small bowel and large bowel. But the biggest one there is small bowel. So if you get best value for your buck, you put your money where roughly the small bowel is, and that is just below the umbilicus. Like this. We usually listen on the side, down here, just a bit below and a little bit lateral to the umbilicus. And here I can hear bowel sounds. They're tinkling. They're occurring almost every second. Some are gurgling. He's obviously had his breakfast and some fluid is percolating through his small bowel and I can hear it. That's normal. So, and then I check over there. You see where I'm listening and I can hear the sound. So, tinkling bowel sounds are normal. Whenever we get a dose of diarrhea, you can actually sometimes hear your bowels moving. That's called borborygmi. And they're audible to you. Just like wheezing is audible in the chest, you can actually hear them. And then you know that something's going to happen. But that's just to dismiss what I call the normal range of bowel sounds that you may encounter. What you are interested in is pathological auscultation. And that, what we have to do for that is you listen and you check if bowel sounds are present. And let's imagine here they're not present. Now, how long do I listen for? Well, the teaching is you must listen for 3 minutes. Now, 3 minutes is a long time for a student or a young doctor to listen, a busy person. But technically, you're meant to listen for 3. And if they're not there, they're not there. That means bowel sounds are absent. So that's the first big abnormality on auscultation. The second abnormality is bowel sounds can be increased. And we get that with mechanical obstruction. And if you listen with your stethoscope, now you're going to hear high-pitched sounds that are tinkling, fluid is getting through, and are increased. Now, the only thing I can say is that the best way to understand abnormal is to listen to what is normal. And I emphasize that with students, that auscultation is a skill that you have to get. Just like the cardiac auscultation, you know the normal heart sounds, therefore you know the abnormal bits. Abdomen is no different. So we've mentioned 2 abnormalities. 1, total absence of bowel sounds after 3 minutes of auscultation. 2, bowel sounds increased, audible with your stethoscope. The last thing is the quality of the sounds. Now, occasionally you will listen to an abdomen and all you will hear is a little sound that can be low-pitched and just periodic. In other words, bowel sounds are decreased but not absent. It may be a high tinkling sound, just 1 or 2. And the comment will be bowel sounds present but decreased. And then you may say something about the quality. They're either very high-pitched, tinkling, or what we call low-pitched. And you can just leave those 2 hanging in midair. Bowel sounds come into play when you suspect an acute abdomen. And it's the bread and butter of surgeons, of obstetricians, and of course physicians when we encounter an acute abdomen, but we are less involved in that side of it than surgeons. The last bit I want to say now before this examination finishes is examining the inguinal area, the femoral area, looking at the genitalia and doing a rectal examination. Now the teaching is if you don't put your finger in it, you put your foot in it. In other words, you make a mistake. And this happens so often. More mistakes are made by not looking than by not knowing. So please remember, you must do a rectal examination. It's ever so simple. You take a glove finger, you put a bit of Vaseline on it, you look at the perianal area before you put your finger in, you place the tip of your finger, what we call the pulp, against the anus, and then gently press it. The anus will release. You put your finger in, and then you palpate the anterior wall. In a female, you're going to feel the rectum, and through the rectum, the cervix. In a male, you will feel the prostate. And define its 2 lobes and the median raphe, whether it is normal or abnormal. You will then complete a finger examination of all 3 walls. The posterior wall, the wall behind, and the right and left lateral wall. You will withdraw your finger and you will look at it and say what's on the glove. And that will complete the rectal examination. Now, I'm not going to demonstrate inguinal adenopathy on our student, and for obvious reasons, or examining the femoral veins for his privacy, but in practice, that's easily available to you. Now that completes the abdominal examination.